Overview of assessment, the key to success in long-term care. This is the first in a series of programs related to assessing residents in long-term care settings. It will present an overview of the assessment process. This program is offered by the Beacon Institute through a special grant from the Office of Healthcare Quality. This series will lay the foundation for a better understanding of the assessment process in long-term care, and hopefully will increase your skill in recognizing and responding to changes that affect resident outcomes. As you know, in long-term care, we work in a highly regulated environment, so it's important to understand how your assessment skills not only impact the residents' outcomes, but the facility's performance in meeting regulatory requirements. The intent of this program is to enable you to define assessment and explain its role in the nursing process, discuss regulatory requirements concerning assessment, identify methods for collecting assessment data, identify various types of assessments used in long-term care and when they are to be performed, discuss how to identify and respond to a change in condition, and identify and discuss ways to avoid common pitfalls of assessment documentation. There is emphasis on the word process. Assessment is not simply completing a form. Assessment forms are tools we use to collect data, but after that data is collected, we need to evaluate that data to make sense of what it means for the residents in our care. Through evaluation of data, we can identify what is normal and not normal for the resident, and what needs to be done to maximize residents' health and function. We also recognize that the residents' needs and strengths involve more than the physical realm. The psychosocial environment and an individual's spiritual beliefs greatly influence physical status and outcomes. These factors are important to consider when planning care for residents. Do you know what each letter of A, D, P, I, E stands for? You may have determined that they stand for assessment, diagnosis, planning, implementation, and evaluation. Assessment is not a standalone process. It's incorporated within the nursing process. Does it matter what order we complete the steps of the nursing process? Yes, it does matter. Assessment always comes first. Remember your ABCs. Assessment before care. Yes, we have formal assessment structures within long-term care, but we can and should be doing informal assessments with each interaction with our residents to confirm that our care is appropriate. For example, what do we do before we give digoxin? We take a pulse. That is collecting assessment data. Now, if the pulse is below the parameters set by the physician, would we still give the medication? No. Before delivering care as planned, we must confirm that the resident's status isn't different from his or her normal. Taking the time to develop a sound nursing diagnosis helps to direct individualized care, as the goals and interventions should target the specific information you have identified in the nursing diagnosis. A well-stated nursing diagnosis will take the guesswork out of identifying goals and interventions that are tailored to meet the needs of a specific resident. The related to factors serve as the target for your interventions. The as evidenced by will help you to identify goals. The evidence is the current state of being. How would you want to improve that? What symptoms or outcomes would you want to minimize or eliminate? Communication of the plan to all involved in care is critical to the plan's success. What are your current communication channels to share care plan information? Evaluation involves reassessment to determine if the resident has been able to meet care plan goals. After we collect data on the assessment tool or form, we cannot forget the crucial step of reviewing that information to figure out what it means for the resident. Remember that assessment is the foundation for the care that we plan and provide. If assessment is not complete or accurate, it will affect the quality of care that is provided. So, assessment is more than just completing a form. It involves tools and forms that help us collect the data in a systematic way. But it's not complete without analysis or evaluation of the data we have collected. Assessment is the foundation for all the remaining steps of the nursing process. There are both federal and state laws that govern how and when assessments are to be done and how assessment information is to be used. These laws are intended to protect the vulnerable in our care to assure appropriate and competent care. The federal laws governing nursing homes are found in the Omnibus Budget Reconciliation Act, known as OBRA. You may find it odd that nursing home laws are in a budget act, but it makes sense if you consider that there's a lot of government money that pays for nursing home care. In order to receive government payment for care, facilities must meet the care standards of the law. Now pay particular attention to the words in bold. We have to provide care and services to help residents attain and maintain the highest practicable level of care. What does that mean? To attain, we are helping the resident reach a goal so the resident should improve. To maintain, we are trying to make sure that the resident remains at the current level of care without showing decline. In other words, the best case scenario is that we help residents get better. The worst case scenario is that they remain exactly the same. Residents should show no decline unless we can prove that the decline was clinically unavoidable. You will only be able to do this if you are careful about documenting your assessment findings and follow through with the nursing process. If you look at the surveyor guidelines, what words are bolded? What do those words reflect? Yep, the nursing process. Maryland law mirrors federal laws in supporting the nursing process, but Maryland law, known as COMAR, also requires a concurrent review. This is to assure that changes in status are properly recognized and evaluated so that proper care can be given to prevent negative outcomes. Let's focus on the right-hand side of the screen. If there has been a change, physical or mental, then the nurse is to evaluate those items listed under the bullets. Many of you have concurrent review forms that include these various items. They appear on your assessment form for a reason. We need to gather data on all of these items, not pick and choose what you think is relevant. You may not recognize its relevance to the resident's change in condition until you collect and review the data. We will come back to this under the last objective, but just recognize that these items are included by law. The Nurse Practice Act denotes who has what responsibility for assessment. By law, there are differences in the roles of the RN and LPN. In essence, the RN is responsible for analysis of the data, formation of the nursing diagnosis, and development and oversight of the plan of care. The LPN contributes to the assessment and assists in the care under the direction of the RN. Let's review some key points. There are regulatory requirements and professional standards related to assessment that we are expected to meet. The RN has ultimate responsibility for collection of adequate data and analysis of that information to form the nursing diagnosis. The LPN assists with and contributes to the assessment under the direction of the RN. The federal regulations require that we provide care and services to help the resident attain or maintain the highest level of care. The state laws require that we constantly evaluate residents for any sign of change, and that we thoroughly evaluate the nature of that change so that appropriate support and care can be provided. The Nurse Practice Act denotes the specific responsibilities of the RN and LPN in carrying out the nursing process. Let's move on and take a look at the ways we collect data. There are various methods for collecting data. They include record review. What would be important to look at in the record review? Some examples including comparing current status to previous notes, when did this change occur, looking at medications, lab values, consult reports, notes from other disciplines, etc., are part of what we would consider. Observation and inspection refer to the conscious, deliberate use of the senses to gather information. Without any words being exchanged, information about a resident can be gained by a general observation of the body, movement, and the detection of unusual odors and sounds coming from the resident's body. Specific observations to consider include general level of consciousness, alertness, general appearance, cleanliness, grooming, appropriateness of clothing, body language, ease of movement, quality and appropriateness of speech and language, skin coloring, discoloration, cuts, bruises, sores, growths, unusual sounds such as wheezes or gurgling, odors, for instance that they may be coming from urine, feces, the breath, or the vaginal area, reaction to touch, skin temperature, reaction to conversation and questions. The interview is a structured verbal exchange. Although the major purpose is to gather information for the assessment, it also serves to provide information to the resident and/or the resident's representative and lay the foundation for the relationship. The following actions can facilitate an effective interview. Make sure the resident is comfortable. Explain the length of time the interview should last and ask if the resident is able to dedicate that time. For instance, expecting visitors or feeling tired could influence the time the resident is willing to commit to the process. Be aware of any hearing or vision deficits that could interfere with the interview. If used, assure hearing aids and eyeglasses are worn. If hearing deficits are present, compensate by speaking loudly. Use a level of language that is appropriate for the resident. Determine if the resident is not fluent in English and obtain an interpreter. Provide sufficient time for responses, recognizing that older adults may need more time to process information and formulate responses. Listen carefully to responses. Validate information obtained to assure that you have an accurate understanding. Use different styles of questions based on the information being sought. Closed-ended questions are effective when direct, short responses are appropriate. Examples include, how old are you? What type of work did you do? And how many children do you have? Open-ended questions are used to elicit more detailed descriptions and often can yield insights into the resident's mental status. Examples of open-ended questions include, what has been your usual daily routine? What would you like to achieve from physical therapy? And how would you describe the pain you were having? Physical examination is an important part of assessment and consists of several parts. Auscultation, which is listening to sounds within the body with the use of a stethoscope. Different sides of the stethoscope are used to hear different sounds. The diaphragm side is used to hear higher pitched sounds such as bowel sounds, normal heart sounds, and lung sounds. Lower pitched sounds such as heart murmurs are best heard with the bell side of the stethoscope. Percussion. That is the tapping on the body's surface to determine the underlying structure, size, and consistency of organs and the presence of fluids. Palpation. Touching and manipulating various parts of the body to determine the size and location of organs, temperature, presence of unusual growths or fluids, and tender or painful areas. As you can see, many skills are required for this activity. We use most of our senses in the collection of data. We aren't using taste, but we do use our sight, our hearing, our sense of smell, and touch. In addition, we use our intellect in reviewing the data that is available to us. We will be talking in more detail about these processes when we get to the classes on specific types of assessments and the skills required. To review, we gather assessment information from multiple sources. Everyone who interacts with the resident may have something significant to share. We observe, we listen, we touch, we smell. The medical record holds important information to direct, supplement, and/or validate assessment findings. Let's now look at the types of assessment used in long-term care and when they are performed. We use multiple assessments in long-term care. These are some of the most common, but your facility may have additional ones. These are generally the formal assessments that we complete, but we also have informal assessments. These occur during our day-to-day interactions with residents and are often when we detect a change of condition. Usually, facility policy dictates when formal assessments get done. Policy often reflects what regulations require. Informal assessments often trigger assessment for change of condition or concurrent review, so these can happen anytime. I want to draw your attention to the last two bullets, as these are often missing in assessment documentation. We most often do a change of condition assessment when something has gotten worse, correct? Remember, the federal regulations state that we have to help the person get better or at least stay the same. If something about the person has gotten worse, then we need to assess what is going wrong and establish a plan to fix it. Therefore, we must monitor the person's status after a noted change and determine how the person is responding to the care to correct the problem. Remember that if the person shows a decline, we must have documentation that proves that the situation was clinically unavoidable. How we monitor and adapt care to help turn the situation around helps to provide that proof that we did everything we could have done. Please don't forget to document a resident's condition anytime the person leaves the facility. This doesn't have to be a lengthy assessment, but at least enough information to reflect that the person is stable. For instance, if they're going out on a routine appointment or leave of absence, or to validate the clinical status with an emergency transfer. Failure to do so may have legal implications. If we are spending this much time of our nursing day completing assessments, assessments must be important. What are we doing with all that information? Let's move on to identify and respond to a change of condition. Sometimes this data is based on our own knowledge of the resident. In our daily interaction, what are examples of some changes we might notice based on our observation and knowledge of the resident's usual status? Some examples could include color, facial expression, bruising, a need for more assistance, verbalization of a new complaint. Those are kind of easy changes to detect, but we have to be careful not to miss other changes that are reflected in documentation. This means that we need to pay attention to what information is recorded. Anytime you are recording information about a resident, you need to pay attention to what information is already in the chart. If what you are recording reflects something different than what has been recorded as the resident's usual, then you need to explore this further to determine if there has been a change in condition. Much of the concurrent reviews, or SBAR documentation, relates to obvious changes. We can tell by looking at someone that something is wrong, such as seeing that there is a change in a resident's level of consciousness or that there is respiratory distress. We can also identify these things by listening to what the resident is telling us. or by what the resident reports. However, some signs of significant changes are more subtle, and we need to be on the alert for these changes so that we don't miss them. These can include a change in bladder function or decreased appetite. Many of these changes are found in things that the GNAs report or document, such as ADLs, appetite, weights, bowel and bladder. Unfortunately, most nurses admit to not having enough time to pay attention to GNA documentation. While this is understandable, it is a dangerous situation. If something goes wrong with a resident and signs of change are found in GNA documentation and are never picked up by the nurse, there may be a bad outcome for the resident. But there also are risks to the nurse and to the facility if it shows professional negligence and/or non-compliance. Assessment of a change of condition is a responsibility of good nursing practice, but remember, it is also required by Maryland law to make sure that it is done and done correctly. The tool you use, either a concurrent review or SBAR form, is designed to help you collect data that Maryland law tells you to review. These are listed for you again in the right-hand column. To recap, some changes are obvious and some not so obvious. We must constantly review and compare data to identify when a change has occurred or is occurring. We must assess the resident to identify contributing factors to the change. Let's now consider strategies to avoid some of the common pitfalls in charting assessment data. There are some practices to avoid the pitfalls. The stated change of condition should reflect resident status. For example, started on antibiotics reflects a change in condition but does not describe the change. Why does the person need antibiotics? What were the physical complaints or signs demonstrated by the resident that reflected the possible presence of an infection? Respond to each item on your concurrent review or SBAR form. No blanks, no NAs. As we have previously stated, you don't know whether information is related to the change or not until you review it. Collect all information and then determine if it is relevant. Be objective versus subjective. Use measurements, descriptions, resident statements. Examples of subjective terms are adequate, good, fair, look sick. Instead, use measurements that show the percentage or cc's, lengths, or widths. Compare to prior data and look for changes in values and patterns. Where appropriate, review patterns versus focusing on a single meal. For example, may have eaten 75% of the last meal, but perhaps has been refusing breakfast for the past 3 days. Don't use percentage for fluids, as this does not indicate how much was taken. Use current information to complete vital signs, finger sticks, and/or lab values. Using data from a prior flow sheet may lead to inaccuracies in your evaluation of what is going on. For example, if you use vital signs taken from this morning's flow sheet for a fall that happens in the afternoon, you may have missed a contributing factor, such as an irregular pulse. Another example, if you want to see if blood sugar is a contributing factor to a fall for a resident with diabetes, you need to check a current finger stick versus using one obtained at a prior time interval. Blood sugars can change very rapidly, so even if you checked it an hour ago, it may be significantly different at the time of the fall. Check for changes with medications or those that present risk. When it comes to meds, a lot of your forms ask you if there has been any med changes in the past 7 days. Be sure that you check order changes for new meds, discontinuation of meds, or dose changes. Don't limit your assessment to just answering those questions. Do any of the meds the person is taking present risk for a condition that is presenting itself? For instance, a risk for falls or bleeding. Check for abnormalities revealed through lab work. Are there abnormal labs, and if so, assess for clinical symptoms related to those abnormalities. If there are no recent labs, are there labs that are needed that you can request from the physician or nurse practitioner? Make sure that you assess information in a consistent way with other documentation. For example, when the concurrent review says no abnormal labs in the past 7 days, however, a concurrent review was completed less than 48 hours prior to abnormal labs, or food intake is good, yet a GNA records less than 50% of intake. Document actual times and events to reflect the complete picture of the change of condition. What time was the change noted and how? What action did you take? Was it effective? What time was the physician or nurse practitioner notified? When did you get the response from them? What time was 911 called? What time did they respond? When did the resident actually leave the facility if transferred? What was the condition of the resident at the time of transfer? How did you monitor the resident between onset and transfer? To recap, don't take shortcuts. Make sure that the information is complete and accurate. You cannot adequately analyze the situation if you do not complete or correct information, and your conclusion is likely to be faulty. If your assessment is wrong, the care that you provide may not be appropriate. To summarize, assessment is the foundation of nursing practice. It's not just a documentation task. Long-term care has unique requirements related to assessment. Assessment involves skill in data collection and critical thinking in the evaluation of data. Assessment incorporates input from multiple sources. A good assessment, done according to requirements and standards, lays a path for the rest of the nursing process. This concludes the presentation. Please see related files in the toolkit for more information on this topic. And if you have any questions, please discuss them with your staff development instructor or charge nurse. Thank you.